You stop the vacuum in the middle of the room because you need a minute. Maybe the room is warm. Maybe you did not sleep well. One pause, by itself, does not tell you much. But if the same ordinary task starts making you stop more often than it used to, that change becomes worth remembering. Not because it proves something is wrong with your heart. The useful part is that something about the routine has changed. Many people make one of two choices when they notice something new. They dismiss it completely, or they immediately imagine the worst. There is a much more useful space between those two reactions. You can notice a change without diagnosing it, and you can bring it into a conversation before you know exactly what caused it. Take breathlessness. The American Heart Association includes shortness of breath and unusual fatigue during ordinary activity among changes that can appear with heart failure. But shortness of breath is not a heart failure test. A major heart failure guideline makes the limitation very clear. Breathlessness is a complex symptom. The heart can be involved, but so can the lungs, physical conditioning, anemia, medications, infection, and other factors. So the important question is not, does getting winded mean heart disease? A much more useful question is, has something I could normally do started feeling different? If you like learning where ordinary changes stop being background noise and start becoming useful questions, subscribe to The Quiet Heart. Maybe vacuuming one room now requires 2 stops. Maybe carrying laundry across the house leaves you unusually drained. Maybe you finish a routine task and need noticeably longer to recover than you did a few months ago. None of those observations can identify the cause, but a repeated change in what an ordinary activity costs you can be useful information for a healthcare professional. That is very different from waiting until something becomes dramatic. The next clue changes the setting completely. Instead of asking what happens when you are active, it asks what happens when the effort disappears. You lie down. The room is quiet. You are no longer carrying anything, cleaning anything, or walking anywhere. But breathing feels less comfortable flat on your back than it does sitting more upright. Some people notice that they have gradually added another pillow. Others wake during the night feeling short of breath and sit up because breathing feels easier that way. There are several reasons breathing can change with position, and some have nothing to do with the heart. But the pattern itself is useful because position has changed the experience. The American Heart Association includes difficulty breathing while lying flat and waking at night short of breath among symptoms that can occur with heart failure. That does not mean everyone who sleeps on extra pillows has heart failure. People use extra pillows for reflux, congestion, back discomfort, habit, sleep apnea, or simply comfort. If someone has always slept comfortably with 2 pillows, that is different from someone who used to sleep flat and has recently started needing to sit more upright because breathing feels different. The number of pillows is not the diagnosis. The new relationship between position and breathing is the information. And the next clue is different again. You do not notice it because breathing changes. You notice it because for a moment, your heartbeat itself becomes hard to ignore. Sometimes it is a flutter. Sometimes a pounding sensation. The heartbeat may suddenly feel fast, uneven, or simply different enough that it pulls your attention away from whatever you were doing. Palpitations are common, and many episodes turn out not to be dangerous. Stress, caffeine, medications, dehydration, and premature beats can all play a role. But a new pattern that keeps returning is still worth describing. The American Heart Association includes palpitations among symptoms that can occur with heart rhythm problems. Feeling a flutter, however, does not tell you which rhythm produced it. A sensation is not an ECG. What makes the observation useful is the pattern around it. Did it happen once for a few seconds after a stressful moment? Or has the same unfamiliar pounding started showing up Repeatedly while you're sitting quietly? Does it disappear almost immediately? Or does it last long enough to interrupt what you are doing? Does anything else happen at the same time? That information can help a healthcare professional decide what deserves further evaluation. Trying to name the rhythm yourself usually adds less value than describing what actually happened, and this is where the 5 clues need to be understood differently. They are not 5 miniature diagnoses. They are 5 examples of an ordinary experience becoming specific enough that it may deserve to be carried forward. The important difference may be that something is new. It may keep returning. It may begin interfering with something you normally do. Or another symptom may start appearing alongside it. You do not need to solve the medical puzzle before the observation becomes useful. That matters even more with the next clue, because lightheadedness is easy to dismiss. You stand at the kitchen counter and suddenly feel as if the room has shifted. You reach for the counter until the feeling passes. Maybe it lasts only a few seconds. A brief episode can happen for many reasons. Dehydration, medications, standing up quickly, a vasovagal response, and other factors can contribute. But repeated episodes of marked lightheadedness, feeling as if you may faint, or actually fainting, deserve proper evaluation. Fainting itself describes what happened. Why it happened is a separate question. The 2024 American Heart Association and American Red Cross First Aid Guidance describes several possible causes of fainting, including common reflex and blood pressure-related mechanisms. Heart rhythm problems are also among the possible causes. That range of explanations is exactly why guessing is not very useful. The more valuable information often comes from the circumstances. What were you doing just before it happened? Were you standing, sitting, exercising, or resting? Did you feel a sudden racing or pounding heartbeat? Was there chest discomfort? Did you actually lose consciousness, or did you feel as if you were about to? Those details help describe the event accurately enough for someone qualified to investigate it. Which of these everyday clues do you think people are most likely to dismiss as just getting older? Tell me in the comments. You do not need to share your own symptoms or any personal medical information. There is also an important difference between an occasional vague sensation and a pattern that starts changing behavior. Someone who feels mildly lightheaded once after skipping lunch may have an obvious short-term context. Someone who has begun avoiding errands because repeated near-fainting episodes make them afraid to go out alone is dealing with something very different. The clue has moved beyond sensation. It is affecting independence. Actual fainting or near fainting that is recurring, worsening, or happening with other concerning symptoms may need more prompt medical attention rather than simply waiting for a routine conversation. And some cardiovascular symptoms change the timeline even more clearly. That difference matters most when discomfort appears in the chest. Chest discomfort changes the timeline because uncertainty is no longer a reason to simply wait and see. Sometimes people describe it as pressure, sometimes squeezing, fullness, heaviness, burning, or a discomfort that is difficult to put into words. It may appear during physical effort. You carry something heavier than usual. You walk uphill. You hurry across a large parking lot. The discomfort appears and then eases when the effort stops. That pattern can occur with angina, when the heart muscle is not getting enough oxygen for the demand being placed on it. But chest discomfort has many possible causes. Muscles, the esophagus, the lungs, and other conditions can create sensations in the same area. So the goal is not to decide at home whether a sensation is angina. It is to recognize that new chest pressure or discomfort deserves proper evaluation, especially when it appears with exertion. And one detail needs to be especially clear. If discomfort improves with rest, that does not prove the situation is safe. You should not use relief as a home test. Heart attack symptoms are not always sudden or severe. They can begin with mild pressure or discomfort, and they can sometimes ease and return. If you develop acute chest pain or pressure or symptoms that could represent a heart attack, including chest discomfort with significant shortness of breath, fainting, sweating, nausea, or discomfort spreading into the arm, shoulder, back, neck, or jaw, seek emergency help. In the United States, call 911. Do not wait for certainty before acting in that situation. That is the boundary that keeps "don't panic" from turning into "don't act." Most of the changes we have been discussing do not ask you to become your own diagnostician. They ask you to become a better observer. You do not need medical language to make a conversation useful. You can simply describe what changed, when it happens, what you were doing, whether it keeps returning, whether anything else happens at the same time. That kind of description gives a healthcare professional something much more useful than, "I just feel off." It also protects you from turning every sensation into a disease label before anyone has evaluated it. Subscribe to The Quiet Heart if you want more calm explanations that help you notice change without turning every change into a diagnosis. There is a practical difference between paying attention and constantly monitoring yourself. Paying attention means noticing when ordinary life changes in a way that is new, repeatable, or disruptive. Constant monitoring means treating every heartbeat, every breath, and every tired afternoon as evidence of danger. The first can improve communication. The second can make normal variation feel threatening. Now go back to the vacuum cleaner in the middle of the room. At the beginning, the pause looked small, maybe inconvenient, maybe easy to dismiss. By itself, it still does not tell you what caused it. But that was never the skill you needed. You did not need to name a disease. You needed to recognize when something that used to feel ordinary had changed enough to become worth describing. Sometimes the right response is a conversation. Sometimes the situation calls for faster medical attention. Calm and action can exist at the same time. You can take a change seriously without deciding what it is.